Dr. Alberti is founding director of the AAMC Center for Justice and is also AAMC Senior Director of Health Equity Research and Policy. For those of you that are not all wrapped up in medical education, AAMC is the Association of American Medical Colleges. He earned his PhD in socio-medical sciences from Columbia University and served as a National Institute of Mental Health Fellow in the Psychiatric Epidemiology Training Program. He subsequently worked in New York City Department of Health and Mental Hygiene that works to promote health equity between disadvantaged and advantaged neighborhoods. He joined the AAMC in 2012, and in his roles there, Dr. Alberti supports the efforts of academic medical centers to build effective programs, policies, and partnerships aimed at eliminating equities in health. He and his team have developed a series of really excellent toolkits. For example, one in trustworthiness and one in community engagement, and we're going to hear some of those. It is my great pleasure then to introduce Dr. Philip Alberti. Welcome to Buffalo virtually.
Thank you so much, Dr. Murphy, for the introduction, for the invitation, and I apologize again for the time mix-up. So I am up to speed now and ready to go. I'm going to share my screen, and hopefully this will work as well. Excellent. Can folks see the slides? Wonderful. So, I, again, am appreciative to be here. Wish that it could be in person, and maybe next time it will be. I know that I have so much to learn from the incredible work, and not just at the CTSI, but at your Community Health Equity Research Institute as well. And so I am well aware that I'm speaking to a bunch of experts. And so I hope that even though I have the unbelievable privilege of 40, 45 minutes of uninterrupted time, this is really a dialogue and a conversation. So please flood the chat, flood the Q&A. If we can't get to all of the questions at the end, we can dialogue and talk after. It is really open for all of that. So I'm going to start off with this phrase that we like to say a lot in the Center for Health Justice, which is if health equity is the goal, health justice is the path. And so I know that this audience probably has a very clear mental model of both health equity and health justice, but I like to spend some time kind of unpacking some definitions, not because I think I have all the right answers, but because I think it's important if we are going to dialogue that the biases, the perspectives, the understandings that I'm bringing to the conversation today. And so we'll start with health equity as the goal, maybe very familiar to many of you. But I do want to point out that we are literally right now in the peak of what the heck is health equity. So this is a Google trend analysis that I ran this morning, showing you the popularity of the search term health equity from the beginning of Google until today. And right here, January 2022 is the most that health equity has ever been searched. So even though this crew today has a good sense of what we're talking about, I find that really adding some contours to the conversation can be useful. So I tend to think about equity in three ways. So I think about equity for populations within an organization. Equity, diversity, inclusion really focuses on some of that work. I think about equity between patient populations or healthcare equity. And I think about equity between communities in health and health equity at the most broad level. And of course, these are not hard and fast distinctions. These are all connected, right? An equitable healthcare organization where faculty, staff, learners are treated equitably, produce better health outcomes for patients, more health equity. And of course, if we believe the county health rankings model, healthcare access and quality contribute 20%, 15, 20, 25% to health equity and population health within our communities. But I think there are some really important distinctions in terms of the goals of each of these flavors of equity, the actors, the different multi-sector expertise that has to be in play to achieve our goals and pull our levers. So we're going to tear through the first two because today's talks really focus on community health equity. But I think it's important to lay some groundwork. So we'll start with populations within an organization and equity, diversity, inclusion. So there's a whole bunch of phrases and things, and I will own up to this. This is the area in which I am least knowledgeable. My training, my practice, the work that I do at AAMC really does not focus on organizational equity, diversity, and inclusion and concepts like pay and promotion equity, accessibility, employee engagement and research groups, how we advocate for the equitable application of policies across our organization. These are all important social, racial justice constructs that we can and should be engaged in, but that's not the focus of today's talk. I do want to spend 2 minutes on the relationship between workforce diversity and health equity. And the only reason that I want to do that is because I have spoken, it probably wouldn't be unfair to say, in the decade that I've been at AAMC, hundreds of conversations, thousands of conversations with academic health centers across the nation. And when I say, so tell me what you're doing about health equity, the first and loudest response is always workforce diversity, which I just want to unpack for a little bit. So I think at the root are social, racial, and economic injustices. These are the fundamental causes that we are grappling with, and some downstream impacts of this disease of social, racial, and economic injustice. On the one hand, we have the lack of workforce diversity, an educational path through which social, racial, and economic injustice operates. We also have the health path towards health inequities, right? That these same injustices give rise to inequities that we see in health and health outcomes. And of course, that makes sense, right? Because the social determinants of health are the same as the social determinants of education or of wealth or of food access or of avoiding incarceration. They are all the same things. And there's a reason, right, that social determinants are inequitably distributed across our communities. And as my great friend Daniel Dawes coined it, these are the political determinants of health, right? We make choices that either inadvertently or on purpose, depending on your perspective, maldistribute the vital conditions that all of our communities need and lead to the kinds of health care inequities that we see on that health path and educational inequities that we see on the lack of workforce diversity. And as we all know, we can't treat one symptom, health inequity, by solely addressing another symptom, lack of workforce diversity. We have to find ways to collaborate together and dig our shovels as deeply as possible to get to those economic, racial, and social injustices together. And so I want to posit today that addressing the lack of EDI in medicine and research, importantly, is an imperative that we all must be 100% committed. And at the same time, it is not a sufficient health equity strategy. So I want to make that crystal clear. And there's an incredible, if you haven't read this perspective by Drs. Cruz, Collins, and Cooper, I really suggest you check it out, kind of this opening conversation to really distinguish the complementary efforts of workforce diversity and health equity. And if you are deeply interested, as I am, in equity, diversity, and inclusion in the research enterprise, particularly for clinical and translational research, I'm sure you've seen this as well by many of your colleagues across the CTSA consortium. This is an outgrowth of, I believe, your 2020 CTSA or ACTS meeting. So that's all I'm going to say about that first flavor of equity, because that's kind of all that I can say, again, given my own training and expertise as a social epidemiologist and a public health guy through and through. We're also not going to spend a lot of time talking about healthcare equity, which I do love to talk about, and I have spent a lot of time thinking about increasing health access and quality for all patient populations. But there's a whole other set, a whole new parking lot of terms and phrases that folks that are really focused on creating health opportunity for patient populations might want to dive into. I've spent a lot of time, for example, maybe too much time, thinking about Z codes, thinking about healthcare policy around value-based purchasing and social risk adjustment. And you can see many other concepts as well. And we're not going to really focus on the work of the healthcare system in promoting healthcare equity between patient populations. We're really going to focus on community health equity. So getting that kind of out of the way, now that you understand where I'm driving from for our conversation today, what do I mean? What does the center mean when I say health equity is our goal? We've spent a lot of time, not just my 2 decades in the field, but as a team, coming up with this goal. Health equity is every community begins at the same starting line for health. And I think we landed here for 2, I think, subtle but really important reasons. So first, the stress is really on community, right? Health equity is not produced one individual at a time through one individual patient-provider interaction, one individual researcher community interaction. It really is about the aggregate, our neighborhoods, our demographically defined communities, et cetera. The other important point here, and I'll go back one step, it is a population health dynamic. I think that's the key. Health equity and health inequities only exist at the population level. Patients do not have health inequities. The communities from which your patients come from have health inequities. The other important point here is that it's about the beginning and not the ending, right? Health equity is about creating opportunity and not about creating the same endpoints. And this is kind of a lowercase p, I think, political imperative. You might have noticed that there are a lot of folks, and maybe one could characterize it as an anti-equity position. We've certainly felt some of the anti-equity perspectives and heard that loudly and clearly from our own work. And one of the themes that comes through in this anti-equity perspective is that health equity, or any kind of equity, any of the flavors, and this is a paraphrase, is inherently un-American because we are concerned with mandating equal outcomes for everybody. Kind of taking our strength, which is our focus, even that WHO definition is about creating a place where every community has the chance, the opportunity to be as healthful as it can possibly be. And so we are really working to ensure that all of our work is focused on that goal of creating opportunity and not just making sure all populations have the same health at the end. And that has real implications for measurement. So here's a call to action for the scientists that are speaking and listening and learning together for this summit. But measuring health equity is not the same as surveilling health inequities. Measuring the gap, measuring that outcome is important to understand progress, right? But first, not all differences in health are inequities, not all disparities are inequities, right? Inequities really have to be rooted in that social, economic, racial injustice, not just any benign difference in health between groups. And we're not really beginning to measure the opportunity creation. What does it feel like for patient populations, for communities, to feel and believe that they have an equal opportunity to be healthy? I think that's really the vanguard of measurement. And I think I'd love to have some exploratory conversations with you and your experts, of course. So if that's health equity is the goal, then the next piece is health justice is the path. And so here's a little bit more of maybe my perspective on why the center landed on health justice as the framework that can lead us to that equitable opportunity for health and where that comes from. So I mentioned I'm a public health person, a public health scientist, social epidemiologist, and my first big boss in the world was Dr. Tom Frieden in the New York City Department of Health and Mental Hygiene, who of course went on to head up the CDC under President Obama. And when he was transitioning from New York to Atlanta, he had begun work developing, I'm sure this looks familiar to many people, this is the public health impact pyramid. So really trying to quantify, if we want to have impact on population health, remember health inequities are population health dynamics. What has the biggest impact in terms of our interventions and what has the smallest impact? So important to note that it also says that we need interventions at all of these levels. So even though some have bigger impact than others, they are all necessary and they are all insufficient. That said, the smallest impact for population health is kind of like the bread and butter of academic medicine, right? It's counseling for patients. It's one-on-one interactions. It's stuff that happens in a doctor or a nurse or a PA, kind of that one-on-one clinical attention. If we are really focused on creating equitable opportunity for health between communities, counseling, clinical interventions, the least impactful. That means the most impactful, we go down that pyramid, are changing the context, directly addressing socioeconomic factors like housing, inequality, education, these social determinants, these vital conditions. Far be it for me to improve upon or suggest amendments to Dr. Frieden's pyramid, but I think there are two important levels here that are missing that actually serve as a deeper foundation for the pyramid. So one I already mentioned, right, the political determinants of health. If you haven't read Daniel Dawes's book about how our political decisions are at the root of that maldistribution of socioeconomic factors and the differences between the contexts across our communities, I really urge you to do so. But it's not just policies, kind of willy-nilly policies. There's very specific aspects to policies. And it's how fundamental root causes like racism, like classism, like homophobia, like misogyny get embedded in our policies. Those policies in turn create that inequitable distribution of social determinants, which then in turn eventually way downstream lead to the health-related social needs that physicians, nurses, PAs, community health workers are grappling with in clinical settings. So I want to unpack, and we will in a moment, the fundamental root cause. This is very much the frame and the theory in which I came up. So full disclosure, my mentors, Bruce Lincoln, Joe Phelan, developed social conditions as fundamental causes of disease theory. But from this pyramid, what I learned in my practice is that we have to dig deeper. Yes, we need individual counseling. Yes, we need clinical interventions, but we also, for all of our organizations, have to dig as deeply as we can to impact across all levels. And so that takes me to those fundamental root causes. And so let's explore racism as a fundamental cause of disease. So about a year or so ago, we were asked in our scientific affairs team to put together a not exhaustive reading list. I'm sure it's already outdated, that really depicted a list of pathways, the different ways through which racism operates to impact both an individual and a community's health. Again, this is a not exhaustive list. We could add pathways all day. But here's the thought experiment. Like, imagine that we were perfect in healthcare, that we completely remove all racism, all bias from our practice, from our technology, from our clinical decision-making tools, from our textbooks, imagine this amazing fantasy. Fundamental cause theory says, well, that's great. You've closed off one pathway. But the thing about fundamental causes like racism and classism and homophobia and misogyny is that they're clever. And the minute you block off one pathway, they will come out through other pathways. And that will therefore, what I now term, that will frustrate your inner social justice kitten. That will keep trying to tamp down one pathway at a time, and then all these fundamental causes pop back up in other places. So the lesson that I took away from this is that we have to have an aligned, coordinated, multi-sector approach to population health dynamics like health inequities. It is not the job of medicine and public health alone, even in deep collaboration, authentic collaboration with community partners and residents. That is insufficient. It is all of us together. It is food justice and housing justice and urban planning and parks and rec. I mean, you keep naming it. All of the sectors have to really build this together if we're going to be effective. And so all of this really distills down to this core belief in our Center for Health Justice, which is that to achieve health equity, medicine, and you can plug in any sector, medicine, research, public health, must be the best partner it can be in the multi-sector collaborative necessary to change underlying structures and systems. It has to be aligned, coordinated, and digging as deeply as we possibly can. And that's what brought us at the AAMC and in our center to the framework that you see footnoted here by Emily Benford, an incredible housing advocate and lawyer. Please check out her initial paper, to the framework of health justice. And the way that we have operationalized health justice at the AAMC is like this. We say that we have one foot in community wisdom and of that non-negotiable expertise. We have the other foot in a research to policy action imperative, right? It doesn't just end with the publication of the science. How are we going to use that science? And we use both of these feet to walk in a very explicit way, an anti-racist and anti-discriminatory way towards health justice. And that means for us really focusing on those root causes, those social, political, economic injustices, and not just any benign health difference between communities and between populations. I also want to importantly note that to the community wisdom side, we've also added explicitly multi-sector partnerships, calling that out as another non-negotiable element of our health justice framework. And so that brings me to the AAMC Center for Health Justice. So I want to start talking about that community wisdom and what that means and how a national organization like the AAMC and the AAMC Center can walk the walk on true, authentic community engagement to the best of our ability when community engagement, all communities are the AAMC's communities in a sense. And so I'm sure many of you are familiar, could probably see this with your eyes closed and recite it with this community engagement continuum that comes from the CDC and their second edition of their principles of community engagement, importantly being updated right now to a third edition. And we at the center truly believe, we know that all of our institutions are great at outreach, are great at consulting, are great at involving, are great at saying, hey, we experts in academic medicine have a bunch of great ideas. We're not sure they're great. Do you think our ideas are great? You do, community, think our ideas are great? Thank you for the thumbs up. We've engaged the community. That is not what we in the center are talking about. We are really focused on shared leadership, co-design, co-development from the beginning, understanding that, again, it is a non-negotiable set of expertise and knowledge that resides in Buffalo, in all of our local communities, without which we simply will not be successful. If you're familiar with this, and if you're not, please check it out. This is relatively new, less than a month old from the National Academies, developed by many people within the CTSI community engagement cores, so to speak. This is the new assessing community engagement framework put out by the academies. You can see community engagement at the center as the core strategy to strengthen partnerships, to expand our knowledge, to improve all of our programs and practices, and eventually in the long term to lead to thriving communities. And at the center of these core principles is trust. And so I'm going to pivot now to talk about one of our center's first tools and resources that I hope that you and your researchers and communities will find useful, which is our principles of trustworthiness. Now, I know that trust is a hot topic. I'm sure if I ran that Google Trends on trust or trustworthiness, we're also in peak. How the heck do we get to trustworthiness in 2022 as well? But this is something that has been near and dear to my heart for a very long time. So I don't do this often or ever. But here's the title of my dissertation from 20-something years ago, looking at cultural mistrust of the healthcare system. So trust and stigma, particularly on mental health, has really been a scientific passion of mine for a very long time. So why now, though? Why in 2020, when we started this work, why was our center that we were developing at the time, we hadn't even launched, why were we so focused on trustworthiness? So I think what really chagrined us, and so this is going back pretty much exactly 2 years ago, there was a lot of conversation, a lot of national experts, a lot of physicians and scientists and researchers and self-appointed community leaders talking about trust on behalf of communities, but very few community voices talking about trust. And the framing was really kind of putting the onus on communities to build their trust, to become more trusting, to realize that our organizations should be trusted. And we felt pretty strongly that was offensive. It didn't really get at the root causes of mis or distrust, and that the true onus is on institutions like academic medical centers with power and privilege to prove, to demonstrate to their communities that you are worthy of their community's trust. And so that was our thought going into the development of our trustworthiness toolkit. And so the way that we operationalize tapping into community wisdom and expertise is through our Collaborative for Health Equity, Act, Research, Generate Evidence. The acronym is CHARGE, a little bit tortured, but it works for us, and we like the forward momentum of the charge. So another call to action, if you are not a part of CHARGE, a member of CHARGE, please join. You can see the sign up URL on the slide. There is no barrier to entry, no cost. We are quickly approaching 1,300 health equity champions from across the country. Inherently multi-sector, only about 65% of the participants are from an academic health center. The other 40 or so % are their multi-sector partners. It is not a professional development community. We pitch it as a professional achievement community. So folks in charge are writing papers together, applying for grants together, and working with the center very closely on developing our tools and resources. And so back in January, February of 2020, we put out an RFA for CHARGE participants, said, hey, if any of you have qualitative experience, interview experience, videography experience, we want to work with you on our trustworthiness work. So we had a bunch of applications. We selected 9 individual CHARGE participants from 7 different geographies. And then we collectively developed a strategy, some innovative methods to do community engagement across the country during a pandemic in a socially distanced way, working with IRBs to accept digitized consent docs, figuring out ways that we could get incentives to community members when we actually weren't face-to-face with community members. So all of that's being written up. We have a revise and resubmit on some of those kind of social distance methodologies. But the important point that I want to stress here is that everything that we're about to walk through in terms of the product, the toolkit itself, was really a three-way partnership. So it was the core AAMC Center staff, those 9 charge collaborators, and then over 30 community members from across the country helping to co-develop everything we're going to talk about to the extent possible. So the first thing we did was we had the 9 charge collaborators go out into their communities and interview between 2 and 4 local community members to assess their understanding, their beliefs about trust at the time clinical trials were underway. So trust in clinical trials, trust in biomedicine, trust in research, trust in healthcare, and what organizations like ours, like yours, could be doing to demonstrate trustworthiness. All of those interviews were video recorded. We had over 30 hours of video footage that full, 50-person deep collective watched and qualitatively coded and extracted themes. And if we had time, I would show you the narrowed down, the edited 11-minute video that we produced. It's on our website. Please check it out. But here are some kind of quick takes. Well, can we get white people to try out that vaccine first? Like maybe I'll be second in line, but let's pause. There's a history here. Well, sure, I would probably be in a clinical trial or take a vaccine, but here's a laundry list of reservations that kind of undercut my assertion that I would actually participate. Yeah, I'm not a guinea pig. I'm sorry. There's enough examples that I could cite where that people that look like me have been treated like guinea pigs, so I'm going to sit this one out. Well, sounds like a good idea, but I doubt that I'm going to benefit. And I know who's going to benefit. Your organization and certainly Big Pharma is going to benefit. So I'm not really going to put myself at risk to benefit you when I don't see any benefit to me. And then another very common theme was, I'm just not going to put anything in my body that I don't trust. I don't trust where it's coming from. I'm going to keep the temple clean, so to speak. So we had this 11-minute video and various themes emerged that gave rise to our formal principles of trustworthiness. I'm not going to go through all 10. I'll go through the first 2. But you can see, and I hope that you'll hear, the tone, the tenor is very much not the AAMC. It's very much community voice coming through because the community is already educated, right? That is why it doesn't trust you. This was in response to those conversations, right? Those talking heads in the news saying, we're going to educate the community. We're going to get that magic pamphlet that is at the right grade level with the right jargon. And if we distribute that pamphlet effectively, all the mistrust will just disappear. Again, not the case, patronizing. It doesn't really recognize and take responsibility for the history. The language isn't respectful, right? So how are we communicating with community as a dialogue between equals instead of a one-way lesson? You, researchers, physicians, are not the only experts. Where is the humility? When you want to come and work with us, do so in a humble way, understanding that leadership is partnership. And then can you point to ways in your past when you've actually used community wisdom in your work, that you've taken that expertise and really walked the walk in terms of embedding it into the science, the recommendations, the policy and practice changes. So here's the full list of 10. I think my personal favorite is number 7. There's more than one gay bar, one black church, and one bodega in your community, really, urging us to expand our network when we think about what community engagement is. But importantly, we just didn't put out, an 11-minute video and some snazzy, well-designed, kind of provocative principles. We really wanted to make this a useful toolkit. So there is an action guide that takes each principle and breaks down very specific questions for you to discuss as an organization, for you and your community groups to discuss together, and then some suggested actions, but also some spaces for you and your organization, your research centers, to innovate actions that would demonstrate internally and externally that you are walking the walk on each of these 10 principles. These are actionable, they're not just theoretical. In the rest of our center, there are other elements of our trustworthiness work. So I also wanted to highlight this guide to language, narratives, and concepts that our center in the AMA Center for Health Equity released. And this is really about reflection and how we can ensure that the language that we speak, the language that we write, whether it's in your grant proposal, your peer-reviewed paper, as we've seen recently, your doctor's notes, whether the language we are using is in fact respectful, inclusive, specific, and action-oriented. And so that's the spirit of this guide. And we also have some funding from CDC, where we are really trying to evaluate and strengthen partnerships, hyper-local partnerships through our principles, through some assessments of partnerships, in service of building the kinds of trust and trustworthiness needed to increase vaccine uptake and decrease vaccine hesitancy. We've also, as a center, developed some, I think, a really exciting capacity for public opinion polling, and have released 2 research briefs, I think both of which touch on trust either explicitly or both of which are pretty explicit. So our first is the state of trustworthiness. And I highlight this one finding because this was one of the things that was most surprising to me. So we asked a nationally representative sample of US adults, so over the age of 18 and over. We tested 17 different sectors and asked whether each individual thought that those sectors were likely to treat everyone in their community fairly. So the good news is that none of the 17 sectors tested or rated below 50%. So in the aggregate, across all US adults, every sector was more trusted than not. But look at some of these actual specific findings. So for every single demographic group, and if you go to the website, all the data tables are available for your perusal, the most trusted sector were fire departments. For every racial group, every age group, every gender, every political persuasion. I have been in public health and in health equity, as I said, for 20, 25 years. I don't recall ever partnering with fire departments. So again, I think about that principle number 7. Are we really reaching and working with all of our potential community partners? And are we taking cues from our communities themselves as to which partners would make the most sense? But I'll tell you this, who we always partner with 100% of the time, universities and faith-based organizations. Now, in this graph, they're at the bottom. And it's not that they are not deeply trusted by certain segments of society, but I will say this, there are a couple of segments of society where both universities and faith-based organizations are mistrusted or distrusted. So if our goal is to reach every segment of our community, right, there is diversity within our diversity, we really have to make sure that we are tapping into every community asset, every potential partner. And there's also real implications for some of our healthcare equity and some of our healthcare equity policies, particularly around data sharing. So another huge area of import for the center, beyond trustworthiness, is data for health equity. And our second research brief looked at whether US adults are willing to share medical information, social information, demographic information, internet footprint. No one wants to share internet footprint information. I don't know what y'all are doing online, but that was pretty clear. But one of the findings was that the more that individuals trust either the sharer of the information or the recipient of the information, they're more likely to want their data or think there's benefit of letting their data be shared. And I think we all agree that if we are to implement and evaluate multi-sector health equity focused collaborations, we need some kind of data sharing capacity, not just race ethnicity data. Yes, it's an embarrassment that we still in 2022 lack fulsome race, ethnicity, and language data. But that's like the tip of the iceberg of the data we don't have, right? We don't have health-related social need data in a standardized way. We don't have community-level social determinant of health data at meaningful geographic units, right? Zip code just doesn't cut it for any kind. If you want to work in New York City like I did, zip code is completely meaningless. And I'm happy to share these slides, look at some of these demographic differences, right? Wealthy, young, liberals are super cool sharing their data. That's maybe not all the folks that we want to reach with the importance of data sharing, particularly for health equity and health justice. So data for health equity is a huge area of focus. We have had Hill briefings from the center. We respond to comment letters all the time. Importantly, we engage charge in our comment letters. So if you are interested in getting more involved in advocacy, when we are about to respond to a comment letter, we have a just-in-time webinar for charge. We get anywhere from 20 to 100 folks. We go through what the RFI is. From the Federal Register, we go through our draft outline. And then we make sure that we are getting on the ground lived experience into our letter. So it's not just reflecting kind of our ivory tower, 50,000 foot perspective, but really embedding local expertise into what we're recommending federal agencies do. One important initiative that I also wanted to plug and pin for you in the Data for Health Equity bucket is our Health Equity Inventory project that you might have seen announced recently. So pretend that this is the House of Medicine. It's actually a house down the street that I lived near in Brooklyn for 15 or 16 years. And let's say we peek into the middle floor of the house that is where all the population health equity related work happens. And it might kind of look like this, a little bit of a mess, right? With a bunch of terms and ideas and related concepts kind of thrown around, not a shared mental model. Maybe I'm being a little bit harsh. I would say that most academic health centers aren't quite this dire, not quite such a mess, because if there's anything that academic medicine is great at, it is building big, beautiful, shiny, gleaming silos of excellence, where everything inside the silo is just on point and wonderful, but no one in community health knows what the service learning folks are doing. No one knows or is employing the health equity research team to evaluate the work of the community benefit arm, for example. And so this has really proven, I think, to be a real limiting factor, right? Getting the internal house in order is a necessary first step to being that best partner outside in our communities in those multi-sector collaborations. So very quickly, back in 2016, we had received funding from AHRQ to build kind of a strategy and a framework. It's totally available. You can walk through it yourself, kind of a DIY systems approach to community health and health equity for academic health centers. And one of the tools that we had developed was our health equity inventory, which currently exists as a tricked out Excel spreadsheet, downloadable and still usable, into which academic health centers across the mission areas can dump in every single piece of community relevant and community partnered work at the program level, the project level, the initiative level. This isn't individual level data. Communities can also enter in data about their organization, who the partners are. And then you can begin to generate reports. Show me everything Buffalo is doing about diabetes in the community. That report comes out. Show me everything Buffalo is doing out of family medicine in collaboration with the mosque across the street around diabetes. That report can come out too. Very, very useful. Many of our pilot sites for this 3-year project are still using it, but lots of limitations. Didn't have FTE data, dollar data, outcome data. It was not cloud-based, could not be used by multiple users. And the community engagement in terms of making sure the tool was accessible to community partners in a transparent way so they could begin to assess what you are doing that they might want to partner. They might want to bring resources to. And so we are currently at the very beginning of an 18-month or so project to enhance the HEI using REDCap. So I'm sure that you are familiar with REDCap, to build the tool, build the survey in REDCap in a way that will really facilitate partnerships, help maintain the kind of coordination of health equity work, both across your institution and more importantly, across your community, in ways that all partners can access, enter data, run reports. And so we are in an engagement phase right now to make sure that we're really crowdsourcing the definition of value. So it's valuable to the research enterprise, valuable to your community partners, valuable to your CFO, and whatever metrics might matter to them vis-a-vis your community health and health equity work. I'll leave you with just a note of our final 2 areas of work. This is kind of the grand experiment of the center. It's all in for health equity. And I'll talk you through what we're trying to do here. So we have lots of data. We have data from our public opinion polling. We can use and tap into new questions. The great thing about that contract is we can ask US adults, where would you invest in your community to achieve better health? And we can have that answer in 24, 48 hours from our pollsters. So we can get a lot of data about what US adults believe would make the most impact for health equity in their communities. We are also convening, and this is something I'm unbelievably proud of, a multi-sector partner group to really walk the walk on that operationalization of health justice, where it's community wisdom and multi-sector partners. So the idea is this: we are going to announce in the next 3 or 4 weeks, 10 members of a multi-sector partner group that represent the diverse vital conditions for health across our communities. Medicine will be one voice, in a chorus of 10. We had an open application process and nominations. For these 10 slots, we got 75 applications. We're going to pay these folks as expert consultants at a rate that anyone on this call would be excited to get paid. And we're going to engage them for a 3-year contract. Their initial task is this: to take data that we can provide, that they can recommend that we get, and we can then obtain, to go back to the constituents that they represent from arts and humanities, from parks, from housing, from transportation, from urban planning, civil rights, et cetera. Get more information, come to the table, and then truly and honestly co-develop together our 4th area of work and bake in from the beginning not only the multi-sector perspectives, but the outcomes that would matter from that work together. So it could be anything. It could be environmental justice, could be housing justice, could be healthcare access. Anything and everything is on the table. This group is going to help us decide the domain, decide our tactics, decide the evaluation metrics, and then hold ourselves accountable through their group and their own constituencies to make sure that this experiment is taking root. The last thing I'll note is our 4th and final area of work is maternal health equity. Love to talk more about this either in the Q&A or offline. We are embarking upon some really interesting health impact assessments to do some policy analysis to understand how things like paid parental leave might actually close or widen racial and ethnic gaps in maternal morbidity and mortality. And please save the date. Registration just opened yesterday for our first maternal health incubator, which is really focused on, again, co-developing from a multi-sector perspective, the kinds of data, systems, and structures that our communities would need to really implement and evaluate and spread and scale effective programs and partnerships that have been shown to close inequities in maternal health and mortality. So there are a bunch of ways to stay in touch with the center. There's our website, the Twitter handle. You can use the QR code and sign up for our newsletter resources. But again, I really see this as an opportunity to start a conversation with University of Buffalo and the incredible community partnered science and scholarship that's already underway. And so I really hope this can be a fruitful conversation starting now and going forward. And again, thank you, Dr. Murphy and team for the opportunity to be here today.
Thank you so much. That was just terrific. Just great insights and a great perspective. Just wonderful. And thank you for leaving nice time for questions and comments as well. I ask people, please put your questions in the chat. Let me start out if I could ask you, and then I see a couple of questions coming in. The trustworthiness issue, and one of the things that that I deal with, I think we all deal with. So we want to engage the community, okay? And then the question is, who and how? So you have a project, you know, should be community leaders? Should it be community members? Should it be, you know, what group or element or people in the community should we engage? Can you just discuss that a little bit about how to approach that question? How to approach that problem?
Sure. My first answer is just say yes to community leaders, yes to community residents, yes to anyone and everyone that will get you the most diverse perspective. And I would say the same internally, right? One of the principles of trustworthiness is, you know, an office of community engagement doesn't cut it. This is something that really is organization-wide. We spend a lot of time thinking about individual competencies, right? For physicians, for nurses, for clinicians, for people on the care team. I spend a lot of time thinking about organizational competencies, right? How does the university's policies support community engagement, science and scholarship, from everything from fiscal readiness, right? The ability to pay very quickly local community partners. That can be a real barrier to incentivizing the work in merit and promotion. But to your question directly, Dr. Murphy, I can recall in my time in New York City, recognizing over the course of 3 or 4 years that very often kind of self-appointed community leaders over time start to kind of no longer reflect the constituency to the same degree as maybe they once did. And so I think making sure that the diversity of community partners is always top of mind If there are opportunities to engage community leaders, also maybe asking, could we also engage some of your constituency? The folks that your organization represents or works with, your clients, your staff, all often have perspectives that maybe the leadership of those groups is unaware of. Takes more time and is more complicated. The arc of this work is long, but I think the inputs are really are worth it in the end.
Thank you. Questions, and actually people can speak if they would prefer or put in the chat. I'll ask you another one then, if I may, and actually you kind of just referred to it, and that is remuneration of community members. And I wonder if you might, your colleague and our colleague and friend Consuelo Wilkins was here giving a talk, and I remember her visit. And if there was one message I came away with when she spoke is, if you are going to invite community members to work with you, make sure you pay them and reward them, and to demonstrate their value. So that's sometimes it's easy to say and harder to do. And I think you alluded to one is quickly and so forth, but you want to do it in a way that does communicate that value, but is not insulting or we want to do it in the right way. Will you discuss a little bit about how to approach that when we engage community members in our, in our focus groups and all the things that we want to learn from them?
Yeah, you can never go wrong with just asking. How do we want to pay you? We value your expertise. We value the wisdom you're bringing. Here are some options. In the past, we've used gift cards, we've used cash, we've used XYZ. I think that's one way. And I think that kind of inquiry, maybe not about the dollar amount that might be set in your budget, but in terms of the way in which it's paid, when you pay, that's part of the engagement and part of that trustworthiness is that I'm not just going to come and tell you what we're offering. I'm really going to just have the conversation. We want to make sure that you feel valued. What's that going to be for you? And it might not be the same for every group, and it might not be the same for every project, right? And a 2-hour interview might be very different than a 1-hour focus group. And so the ask plays a role. I've never gone wrong by asking an honest kind of question. But I also want to point that there's a role, yes, for the institution, for your organization to think about how to do that more quickly and how to get that approved more quickly. But there's also a role for our funders, right? In making money available on a different schedule, maybe even paying community organizations directly, less of a pass-through mechanism. I mean, this work is complicated. And so some of our kind of I would say not our, but our agency is kind of, this is how we always do it. Doesn't really fit for kind of innovative methods in this space, particularly as we are growing awareness of the team-based nature of the science, the multi-sector based nature of the science, the importance of community co-investigators. How do we grapple with that, right? And so I think because the science is innovative, some of those policies also need to be innovative too.
Yeah.
Dr. Alberti, thank you so much for this. This was a great talk and I'm enjoying the conversation. One of the things that I always think about is this is a big job, right? To think about our institutions and our community and all of our different types of community members. And we have very small teams to do this. Do you have any strategies or any suggestions on how we can make the most impact, recognizing these limitations of manpower and resources? Yes.
So again, so for sure, the teams, I mean, and I'm not saying there's turf, but the teams and the turf got to go, right? It really has to be a coordinated effort. And that's really the goal of that health equity inventory, is you can't actually know where the work lives, what assets you're playing with, who's doing the work. You can't ensure that you're not overburdening community partners, right? If you have 8 teams and you're all reaching out to partners A, B, and C, but not D, E, and F, well, A, it's not as comprehensive as it needs to be. And I'm sure your community partners feel a way about it. Like, why are you keep coming back with variations on a theme? And I think that's why, we thought there was real value in revisiting that Excel spreadsheet and making it more useful for for everyone across the organization, so that you can know who's who. If your focus is sexual and reproductive health, who else across the entire University of Buffalo system is interested in that work? Maybe they're not doing community partnerships now. Maybe it's didactic. Maybe it's volunteerism. Maybe it's experiential learning. Maybe it's part of community benefit reporting. Maybe there's in-kind or financial contributions. But you can't know what you don't know. And so I think that inventory, even though it's a big lift for these 5 pilot sites, I think it's daunting to say, oh my goodness, how are we even going to begin to unpack? And who's going to do the data entry? Well, the whole point is you have to do it once and then it's done. And you can update it in a routine way, but then you can go in and say, hey, here's a new grant opportunity. I want to be efficient. I want to minimize redundancy. I want to make sure we're being respectful internally and externally. We're going to look to see who's playing in the space and put together the right team that will require the fewest resources and is the smartest kind of strategy on the external engagement as well. And then there's the other piece of, how do you advocate? I'm a big fan of advocacy, both federal, of course, state and local, but also organizational, right? What does it, and again, it comes back to the organizational competencies, right? How is this work? The building of trust, the demonstrating of trustworthiness can't be left to your project-based work. It can't be, we're only going to demonstrate trustworthiness when we have a need, right? It is ongoing, it is long-term, and it's broad. So how is that? How is breaking bread? We've done, so I took the slide out and I was vacillating, trying to keep time for Q&A. These community engaged toolkits, like the trustworthiness ones, we've done like 4 or 5 others over the years, maybe not as comprehensive as the trustworthiness. And the one theme, whether it was working with incarcerated populations in Boston or refugee populations in Arizona, the one theme that came across all the time is spend time in your community. Break bread, build relationships. So getting back to the policy, how is that work incentivized? How is it captured in merit and promotion, right? Is there an understanding that everyone, whether you're part of these 2 incredible research centers or not, has some kind of obligation? If you're a clinician and you're making referrals to community assets and social service agencies and CBOs, have you ever visited those places? Right? Or are you relying on Bertha to tell you where to go, or NowCom, or Unite Us? Those are great tools, but I think nothing's better than a real warm handoff that says, I actually have chatted a couple of times with the executive and some of the clientele, and here's why I think this asset's the right place for you, right? So how is that incentivized by the organization? So it's not just the only resources you're working with are the folks whose job it literally is. How do you change the culture to make it feel like it's everyone's job? And I don't have an easy answer for that, but.
Great points. Terry Ann Smith has a question related to the issue of trustworthiness you're just talking about. On the comment that the community is already educated and that's why it doesn't trust, what methods can you use to address that specific issue?
So I think there are 2, because I think that principle is doing some double duty. So I think one, it's about recognition of the history that your organization, like the past is always present, is also somewhere in the principles. And your community knows and has a very long memory, longer memory than maybe many of you have. And so I think taking the time, doing your own due diligence to understand the relationship, both current and historic, of the University of Buffalo in place, acknowledging that and talking about how the work that you're proposing moves away from anything negative and builds on kind of that positive recognition. I think the other piece is about respect and language. And so I really tie this principle pretty tightly to that language guide, that concept guide, right? You're implying, right? We need to educate the community. You're implying the community knows nothing. So it could be as simple as just thinking about working with your marketing folks. One of the suggestions in the action guide is look at your most recent communications that go out to your community, your local communities. What words have you used that are kind of denigrating, right? And are there other alternatives that flip it around and say, instead of we want to educate you, we want to partner with you. Could be something as simple as that. You know, I find, and it's interesting, in some of the blowback in trust, there was blowback to this guide. So my favorite was the vulnerable communities. We kind of have a whole piece of not saying vulnerable communities, but I think it's really important, right? If we say vulnerable communities, there's a segment of our country, of the world, that will say, well, why are they vulnerable? Why don't they change that? They have bootstraps, pull them. Like, let's go, right? If you just make a quick switch and say communities made vulnerable, don't have to get into any details or add in the history, well, then it's a different set of questions. Well, who made them vulnerable? When? How? Why? How do we unmake that vulnerability? Right? It changes where the blame goes, it shifts it. It shifts the questions. And so I think language is really powerful. And I know that there's a lot, we could have a whole nother debate about language police, thought police, PC, critical, all these things that are, buzzwords right now. But the reason that there's such feeling and passion about this is because I think we're aware that it matters, right? The way that we frame these issues really, really matter to the work, to our communities, and to the work success. And so I know it's dangerous territory to kind of wade into some of this. Again, lowercase p, maybe even capital P politically. But I think, again, if our goal is to make our language respectful, inclusive, precise, and action-oriented, if those are our guiding principles, we can't go wrong.
Very interesting about your point about language from a very recent experience that we've had here. So in Buffalo, there's no place to go for people with what's called long COVID. And we, the university, are trying to set up a clinic. And so we put together a group, brought in some community members in our east side here, and said, we're setting this clinic up. And we want to make it so it's welcoming, so it's going to work, for your communities. Can you give us any advice? And there was a bunch of advice that was great, actually. But one was, don't call it a clinic. Rich people go to the doctor and poor people go to the clinic. Language. Yeah. This is Dr. Katya Noyes. Any suggestions on balancing the demands of building, maintaining community partnership, and realities of academic tenure and promotion timeline?
I wish that I had the silver bullet on this one. I really wish I do. And it comes back, unfortunately, to that internal advocacy, right? And I think there are institutions that are beginning to think about how community engagement that is untethered from the things that you already are incented to do, right? So community engagement untethered from your ROI. Community engagement untethered from your experiential learning course that you're teaching, that you are getting credit for, right? The routine, the kind of day-to-day quotidian maintenance of relationships, largely absent from our institutions and thinking about merit and promotion. So I think there needs to be some kind of, I'm a little bit of like a rabble rouser, power to the people kind of guy. There needs to be some, agitation to say, if this is a value, and I'll say this, if this gives you cover, and this is not to say that anything I or the AAMC could do would ever give you cover, but like we made a big statement, I think. So Dr. Skorton, our relatively new president and CEO, came on board like two and a half years ago. One of the very first things he did, and some of us wrote a paper about this just last year, was to add a formal fourth mission to academic medicine of community collaboration, right? So it's research, clinical care, medical education, and community collaboration. The center exists as like a main way that we're operationalizing that mission, not the only way. Because again, this work does not just live in our center, it lives across the AAMC, it has to. Similarly, it needs to do that beyond the CTSI and your institute, it needs to live across the organization. So I think if there's a little bit of cover to say, hey, our mother organization is saying this is in fact like an equal obligation of academic medicine, then it needs to have representation in the way in which tenure, promotion, pay is considered. And so this comes up a lot and all the time. And so if there's a way that we can have some groupthink on this, I'm happy to offer a convening place if we want to bring institutions together to explore what that might look like, for sure.
Thank you very
You
much.
talked, oh, go ahead, yeah.
No, just want to say thank you. And it's a tough one because in a large medical center and university like ours, not all faculty obviously engaged in translational research. There's plenty of lab and petri dish based studies that don't require a lot of community engagement, and sort of how to make it fair and equitable and yet pragmatic.
But see, that it opens up all new possibilities, right? So one of my, I am a huge fan of community health needs assessments and asset assessments. And I am so excited when I applied for this job in like 2010, I guess it was, like the ACA had just passed, the CHNA requirement was in there. And I was just over the moon, right? This is a piece of federally required, community partnered health equity research, right? Has to be done every 3 years. And I can guarantee, because we've done our own research, scientists, researchers almost never involved in any aspect of the CHNA. So there's an opportunity. If it's going to be incented, how do you partner with your CFO, with your community benefit office to run focus groups, to run interviews, to do the analysis, to report back on the results of your CHNA to community boards, right? To think through community benefit spend, which I think there are ways to revamp community benefit. For those of you who don't know, right, it's these requirements largely around free care for not-for-profit hospitals. Free care, again, for patients isn't necessarily digging as deeply as that dog in that slide. So how can scientists and educators be involved in some of these administrative components and building bridges between the mission areas? There are opportunities for pedagogy. There are opportunities in GME. Are you modeling patient engagement? Let's extend community engagement to patient engagement. And thinking about, I'm sure you are screening for health-related social needs somewhere, like I'm sure that's happening at Buffalo in some places. Are you modeling patient engagement to make those screens yield the most valid data? Are you stratifying for your learners in the way that you're teaching in the GME space to look for inequities in healthcare based on not just race, but also on housing stability or on exposure to intimate partner violence? I mean, I think the more that you can show that this mission is for everybody, and it's not limited to the places that are already funded to do it or like forced to do it, we begin to get kind of a critical mass of people that might say, hey, I can actually see myself in these new merit promotion guidelines because I do want to contribute to the organization's work in our communities through my data analysis skills for the CHNA. Great, you don't have to be a CBPR practitioner to contribute to that fourth mission in academic medicine. Sorry, that was a lot more. I got all excited.
Thank you. I took notes.
It's a big issue for us, and actually some good comments in the chat as well. That we're getting a little progress in this area. So, and Dr. Noyes is director of team science for our CTSI, and so she thinks about these things every day. When we work with the community, one of the questions, when you're talking about, in my discussions, our discussions, they're not reluctant to talk about the historical mistrust and so forth. And they'll say, you guys do community, you do research and you work with the community. Well, where have we benefited? You're earning PhDs and you're getting promoted and that sort of thing. And you talked about, I like the term used about how our research needs to change underlying structure and systems, and really that's in a sense the big question. And I'll tell you, the new CTSA RFA that's come out has placed a lot more emphasis on D&I, dissemination and implementation research, with that. And a group of us here are working on a center grant in health disparities where that's a clear requirement in the RFA. So we're beginning to think about this more and more. Yep. So here we have academic researchers who think about control groups and biostatistical formulas and all that sort of thing. And they finished this awesome study that shows a very important healthcare advance. Well, what's the next step? And can you talk a little bit about how to help us take those next steps, if you will?
I can, it's so funny. It's so top of mind. So my imposter syndrome is going to rear its head. I'm gearing up to give a talk at ACTS this year on much of this work, and so there's my imposter syndrome. And I've been thinking a lot about like phase 4 clinical trials, right? And how you actually, again, thinking about advocacy, thinking about teeth. Like, it's great for us to want to do this work and to extend into context and place. But if funders are willing to just take the fines and include that in cost of doing business, FDA, I don't think would ever like revoke approval if a phase 4 clinical trial isn't done. That would seem bizarre if the treatment, the device, the drug is beneficial. So I think there's some work to be done advocating for increased teeth for kind of late stage translation. The way that I'm thinking about framing it is everyone makes a big deal that it takes, I think the +1 paper was the median time from kind of molecule discovery through FDA approval was like 36 years. So that gets us to like the beginning of T3, I guess. So then what's the timeline for T4? I guess it's infinity, right? Because no one's ever done it. We've never achieved population health equity for any of the things that we are working towards. And so I think there's some work to do on the capital P policy side around late stage translation, incentivizing it, demanding that it be done. But it's not just about the product of that study. It's also about how we do implementation science, how we do late stage translation in a way that embeds some of these principles and engagement. And there's a couple of great papers that I've come across as I'm thinking about this talk on embedding kind of the dreaded critical race theory into implementation science directly, and what that really looks like in terms of where knowledge exists, how knowledge is produced, the kinds of metrics. And that's the other thing that I'll say. There's a book out that we at the AAMC pre-center worked with Rand Europe, and I talk about this book all the time. It was way ahead of its time. It's called 100 Metrics to Assess and Communicate the Value of Biomedical Research. And so what we did, so if you just Google that 100 metrics to assess and communicate the value of biomedical research, is that our team and RAND engaged different kinds of scientists across the kind of the translational spectrum. So basic scientists, clinical scientists, community partnered scientists, and asked them a series of questions. Who are your stakeholders in your research enterprise? What do you think they care about? What do you care about as real outcomes of your science? We got a whole laundry list. And then, of course, we didn't trust anything the scientists said. And we did our own engagement. We went to local and state and federal legislators. We went to patient advocacy groups. We went to community groups that were convened for this purpose. And we asked them to kick the tires on these metrics to really understand, do these things matter to you, right? Because peer review publications do not matter to your community, to your point, Dr. Murphy. That is not an outcome of the science they cared about. So this book exists, and I've spoken about this like dozens of times. So think about metrics that matter, right? Encourage your community partners to be as selfish as early as they can be in laying out what really matters to them. And then hold yourselves accountable for incorporating that into your measurement framework. And that's why this work, you all know this is preaching to the choir. This is from day one. This isn't like we have our protocol designed. We better scramble and find some partners. It's way too late. You're never going to get to, even if you did an effective phase 4 trial, it's never going to, the process is as important as the product. I'm full of all these like sticky maxims, I apologize. But that's something else that we really hold ourselves to. The way you do this work is almost more important than what you get at the end of it. And so encourage your partners to be selfish. Encourage your internal partners to be selfish. If you want to get support for incorporating community partnerships in your merit and promotion, ask your institutional advancement folks why relationships matter to them. Ask your government relations folks why relationships matter to them, right? And if you can help them achieve their goals, they're going to be very supportive of maybe changing some organizational policy and practice to make it easier to do that day-to-day bread breaking, untethered to an ask that you're making of your community.
Those are great, just a great way to approach it, and very practical things to do as well. Well, boy, thank you so much. This has been just a wonderful talk, and particularly, I think the discussion afterwards has been really give it time to go into a little more specifics and so forth. And I very much appreciate your spending the time with us, and I can guarantee you we will be accessing some of those toolkits from your center that you've developed. So thanks so much, Dr. Alberti.
Well, thank you. And again, any questions, email me. It's a really an open door. Thank you so much.
Thank you.